We had the weekend to be able to not only keep up with the classes, but get a really good solid grasp on capture the weekend, and then have a test so during the week to keep up with the other classes as well. That's my reasoning. Does anybody else have it on the weekend?
Yeah, like during the week, you guys can actually focus on all the other classes and be okay. They're doable during the week, no problem. We get all the work out of them during the week. But then we try to fit in past study time, it's not working. But then the weekend comes, we have like Friday, Saturday, Sunday to study only for PAP. And then it's still fresh in our heads, and then Monday we take a quiz.
Does anybody have any concerns?
Let me just add, if we do moving it to Mondays, this is not something that we can just keep skipping back and forth.
Yes, I agree.
When Mondays get too hard, then we want to switch it back to Fridays. Just keep in mind that 2 weeks from now, we have our first perio exam on a Monday. So we have other classes on Mondays also. And then that following the next Tuesday, we have the pre-clin exam. So it's good to spend that week with perio and pre-clin rather than just I feel like since Thursdays, we don't have, unless you have a block, you have pretty much Thursdays open to study for a quiz after Friday. But you lose that option. You're going to have to do all classes on the weekend.
Yeah, but at the same time, some people have blocks Wednesday and Thursday, and some people have 2 blocks on Wednesday and 1 on Thursday. And then even if there were tests or quizzes on Monday with other classes, that's only going to happen 3 or 4 days out of the quarter, not every week.
Okay, so now that we've all said our opinion, let's vote, and let's do it by a show of hands. Who wants to change the quizzes from Friday to Monday?
Yeah, let's think about your class so she can
Yeah.
start.
Okay, she has to start, so we'll do it another time.
I know. Like Doug said.
I know, it's
Hey guys, please take your seats. Okay, let's stop our discussion if we can. Can you guys hear me? All the way back? Okay, perfect. Okay, I'm Anu Grandi. I'm the other oral pathologist other than Dr. Richards. So I'm going to be teaching oral pathology to you guys. If you have any questions, I'm sorry.
Are we recording or no?
Yeah, that's okay. I'm on the 3rd floor. My office is 3304. So if you guys need any one-on-one help, if you have any questions, I'm happy to help you out during the course of this quarter. So what we're going to do is go ahead, get started with our first topic with oral path. So we're going to talk about physical and chemical injuries. Yes?
Are you on Pinocchio?
No, I'm not.
Okay.
If you guys want to record, go ahead. And I already uploaded the Canvas, on Canvas the handout, so it should be accessible for you guys. It says physical and chemical injuries, and it should be available on modules as well as in files, so if you want to access that. Okay, but I just want you to pay attention to how we approach clinical diagnosis and differential diagnosis. Basically, all the material is on your handout, so try not to spend a lot of time taking too much notes. Just focus on how do you approach these lesions when you see them clinically. How do you come up with a good diagnosis, and what kind of tools do you use to come up with a differential diagnosis, because that's what you're going to use in your clinical practice. Okay. So when we talk about physical and chemical injuries, so basically whenever there's an injury to the mucosa or some kind of irritation, the body has to respond, right? So it comes, it basically demonstrates certain changes in the mucosa. Okay. So the first one that we're going to talk about, it's called linea alba. So what does that term mean? When we say linea, what does that mean? What does the word linea mean? It's a line, right? What does alba mean? White. So it's actually a white line. So that's basically what it is, right? So if you look in a patient's mouth, it basically looks like a white line. Okay? But why do we see these white lines, and where do we see them? So that's a critical thing. And when you do see this, what is it that you need to do? Right? So because these are the questions that the patient is going to ask you. How did I get it? What is my diagnosis? How am I going to treat it? Is this infectious? Am I going to give it to someone else? You know, those are your common questions, right, that the patient is going to pose to you. So when you look at a linea alba, this is a very, very common condition. So the likelihood of you seeing this in your patient population is pretty high. Okay, so why do we see linea alba? There are many reasons why you can see it, but the more common ones is basically when you have irritation of the mucosa, okay, from the facial aspect of the teeth. Do you know what the facial surface, right? Okay, so the side that's basically towards your lips and towards your buccal mucosa. So from that side of the tooth, if there's some kind of irritation to the adjacent mucosa, so that means your inside of your cheeks, inside of your lips, if there's some kind of irritation, then it can create this response called linea alba. Okay, or it could be pressure from the teeth. Okay, that could also create the same kind of response. Or if someone has a tendency to suck their cheeks or suck their lips between their teeth, then that can also create this response. So there's basically, the bottom line is, it's all kinds of irritation can actually lead to this kind of response, right? Some people talk about this being related to like a clenching habit. So if someone, you know, clenches or bruxes, this could be seen as a side effect. But again, there's not much literature out there about, you know, if that itself is a predisposing factor to see these lesions. Okay, so what do we see here? So how would you guys describe this?
White line.
It's a white line, right? So where do you see this white line? What part of the mouth is that? Okay, in the inside of the cheek. What do you call that surface when you see the inside of the cheek? Buccal mucosa. So there's a term for it, right? So buccal mucosa is the inside of your cheek, and then all you're seeing is basically a white line. Let me see if I can get this to work. So you're seeing a white line basically extending from the anterior aspect of the buccal mucosa going all the way posteriorly, right? So, and if you imagine, basically if a patient has a habit of sucking their cheek, you know, and then that gets trapped between, you know, their teeth, then it's creating that line basically at the occlusal plane, right? Because that's where the maxillary and the mandibular teeth are going to meet. So it's basically, when you see these, you're going to see them at the level of the occlusal plane. So keep that in mind. It's always seen at the level of the occlusal plane. Most common site is buccal mucosa, so that's the inside of the cheeks. It can be bilateral or unilateral. So you can see it just on one side or on both sides. Okay, and it's basically a response to an irritation or some kind of you know, sucking trauma or pressure in that area. So if you see something like this, would you want to biopsy this? What would you tell your patient? So you just note it, right? So you basically tell the patient, okay, I see this change in your mouth. Okay, this is nothing to be concerned about. This is not precancer or cancer. This does not require a biopsy. So we're just going to monitor it. Okay, and that's it. So there's no treatment for this condition. Okay, if the patient tells you that they have a habit of clenching or bruxing, then you can, you know, ask them to quit their parafunctional habits, right? And that basically sometimes can help resolve this condition. So if you're aware of any kind of parafunctional habit, you advise the patient to quit them. Otherwise, there's no specific treatment for this. Make sense? So when you see, where do you think you see a linea alba? What is the most common site? Buccal mucosa. Can it be unilateral or can it be bilateral? It can be both. It can be unilateral and bilateral, right? At what level of buccal mucosa do you see this? At the level of the occlusal plane, right? So critical things to remember is this is a white line that usually is seen on the buccal mucosa. It can be unilateral or bilateral, and it's seen at the level of the occlusal plane. And there is no treatment for it. If the patient has a parafunctional habit, you ask them to quit the habit, and that's it. Okay, so this does not require a biopsy. Please don't go ahead recommending your patients to go ahead get a biopsy done if you start seeing these, because that means pretty much 80% of the patients will end up probably getting a biopsy done. So this is not necessary. Okay. Okay. So what other changes can we see if someone has a physical injury. So the first entity that we saw when they have a physical injury was linea alba, right? So there's another change that can also occur in a patient's oral cavity secondary to a physical injury, and that's called Morsicatio Mucosae Oris. Okay, what does Morsicatio mean? Morsicatio basically means chewing. Okay, what does mucosa mean? The lining layer, right? Okay, and if it's oral, oris means oral, right? So it's the chewing of oral mucosa. So that's what it means. That long term that you're seeing on the top, which is the diagnostic term, is Morsicatio Mucosae Oris, means it's chewing of the oral mucosa. Okay, and depending on where the person actually chews their mucosa, you get different diagnostic terms, right? So if they chew the inside of their cheek, the buccal mucosa, what would we call it? Morsicatio buccarum. If they chew the inside of their lip, we call it Morsicatio. What's the lip called?
Labial.
Labial, right? So labiorum, okay? And what is the tongue called? Lingua, right? So it's Morsicatio linguarum. So the term Morsicatio precedes the location. Okay, so if you see the chewing habit on the buccal mucosa and you see changes secondary to the chewing on the buccal mucosa, you call it Morsicatio buccarum. If you see it on the lip, you call it labiorum, and if you see it on the tongue, you call it linguarum. Okay, so that's and then the broad term that kind of encompasses all of these three things would be the Morsicatio Mucosae Oris. Okay, so what do we see here in this picture? So what part of the mouth is affected here? So it's the buccal mucosa, right? Now if you look at the buccal mucosa, does this look normal?
No.
No, it looks abnormal. So what's abnormal about it? Does it look like you have a whitish color change? Do you have a red change, or does it look like an ulcer? What does it look like? Whitish change, right? So it looks like there's some kind of a response that's going on in the buccal mucosa that is white in color. Okay, and does it seem to be localized to one area, or is it involving the entire buccal mucosa? So it seems to be a little bit more diffuse, right? So it's involving a significant portion of the buccal mucosa. Okay, so and if you look at the top of this white lesion, what does it look like? Does it look smooth, or does it look like it's kind of rough, uneven, right? So it looks like it's shredding. So if you imagine someone chewing their cheek, that's basically what they're doing, is they're basically taking the inside of their cheek, inside of their lip, or the side of their tongue and chewing constantly between their teeth. Okay, so what is the kind of response you would expect? Is the tissue is going to peel in that area, and it's going to look rough, and it's going to feel rough, and that's exactly what you would see here. Yes?
So you said it was generalized?
They tend to be more diffuse.
Localized?
Localized means it's just in one specific spot. Diffuse means, or generalized means, you have a significant portion of that mucosa is actually involved. Okay, so this would be considered a diffuse process. All right, if I can make this go back. Okay, so the things, whenever you see this, so how do we differentiate this from linea alba? So we saw two things so far that could be secondary to a physical injury. One was linea alba, and then this is the second one, which is the Morsicatio buccarum. But we have to differentiate between those two things, right? Because they both can have a similar kind of etiology with regards to a parafunctional habit, okay? So in linea alba, you're going to see it as a very well delineated white line that is kind of elevated, you know, when you compare it to the adjacent mucosa, okay? But when you look at Morsicatio, it's not a single line. It's a larger area that gets affected. And then the surface of it has this shredded appearance to it. Whereas you don't see that with linea alba. It's a smooth surface, it's a white line, and it's just along the level of the occlusal plane. Does that make sense? Okay, so if you guys have any questions at any point you need me to repeat it, I'm happy to do that, okay? Because it's critical to understand the difference between different entities, because as we keep moving along, there's going to be a lot of terms that are going to be swung at you, and they'll all look very similar to each other. They'll all sound very similar to each other. So it's critical to know what is the etiology and, you know, how do they present clinically, okay? Because that's what helps you with your diagnosis and differentials. Okay, so if you see this, so the things to look for is this shredded kind of appearance. the involvement of a larger area of the mucosa, and that whitish hue to it is the things you look for when you're looking at Morsicatio. Okay, so you can see similar changes on the inside of the lower lip or on the lateral tongue. It's really hard to traumatize the upper lip. Okay, so the likelihood of seeing Morsicatio on an upper lip is a bit unlikely. Okay, but on the lower lip, it's really easy to get trapped that between the teeth and then chew on it. So most of the changes that you see tend to be more on the lower lip. Make sense? The inside of the lower lip. Yes.
So you said it could be on the side of the tongue too.
Yes. So what happens is the side of the tongue, some patients have a habit of just kind of pushing the tongue between the teeth and then kind of constantly chewing on that when they're like sitting down or when they're stressed. And you can start seeing very similar changes on the sides of the tongue. Okay, and they usually tend to be bilateral when you see these changes with Morsicatio. Okay, and so they don't actually have a very clear defined border. So if you look at it, they're not very defined, right? So if you looked at a linea alba, for example, this is very well defined. You can actually draw a line along the borders of the lesion, and you can tell this is where it starts and this is where it ends, right? But if you go ahead and look at Morsicatio, you won't be able to do that because the borders of the lesion, when you look at them, so if you look at these areas, they're blending with the adjacent mucosa. Okay, so they're not very well defined lesions. Both linea alba and Morsicatio tend to have predilection for women. Okay, and you can also see similar changes as an occupational hazard. Okay, so people who blow glass as their occupation, they can actually demonstrate very similar changes on the inside of their cheek. Okay, so when you talk to your patients, if they tell you that they never chew their cheek or chew their lips, you want to find out, what other things do they do? What is the occupation? Do you use any kind of products that they constantly place in the mouth that can cause, the tissue to get raked against that and then cause these changes? Okay. Yep.
In those cases, is there anything that we can do if someone is...
Unfortunately, there's not much. You just want them to be,
careful.
Just be careful and then be conscious about, what's going on. If it's habitual, if it's a functional, parafunctional habit, then you can encourage them, to basically kind of quit the habit. A lot of times this could also be related to underlying psychological conditions. So if, in conversation, if you do come across, a possibility of that, then you have to refer them, to like the primary care so they can place appropriate referrals to a psychologist. Because, a lot of times patients could do this as a stress reliever. Okay, especially when you're taking PATH, you may want to do that to your face. I'm just kidding. So basically, whenever you see this, you want to make sure that you find out if it's a parafunctional habit, if it's occupational. If it is, then you want to provide, or if it's something related to an underlying psychological, condition, or is it stress, and then you want to address that. Okay, as much as possible within your purview. Okay, so these are the changes that you actually see on the sides of the tongue. If you see this, it looks very similar to the one that you're seeing on the side of the cheek, right? So the buccal mucosa and then the tongue, just the location is different. So keep this in mind. Try not to memorize pictures because the same entity can present, in different locations. It doesn't change your diagnosis. So as long as you learn how to recognize patterns and you know what to look for with the disease process, no matter where it's presented, your diagnosis still doesn't change. So if someone is chewing their cheek or chewing their tongue or chewing their lips, it's still Morsicatio, the diagnosis, right? But the location changes, but the presentation is going to be the same. Make sense? Okay, so it's critical to know that this can, occur in different sites in the mouth when you see Morsicatio changes. Don't spend too much time on histology. This is just for you guys, to kind of know what it looks like. You don't need to, memorize these things. with histology, so if you don't have to biopsy morsicatio lesions, because again you can establish, as long as you can establish a cause and effect relationship. So if someone is chewing their cheek and then this is the outcome of that, then it doesn't need a biopsy. You just have to encourage the patients to quit their parafunctional habits, right? But if you're not sure, and if you actually recommend the patient to get a biopsy done, all you're going to see is this layer on the top. So do you guys know what the different layers are? The basic histology? Okay, what is this layer right here? I'm sorry? So what is the top layer called? Epidermis, right? So it's your epithelium, okay? Because if you look at it, these are individual cells that are kind of clustered together, and this blue cell in each of those cells is the nucleus. So that's how you know this is an epithelial cell, okay? So these epithelial cells now, so this is your epithelial layer, and then on top of that, this thick layer that you're seeing, okay, that's really pink, that's your keratin, okay? And that's why it looks white. So when you look in a patient's mouth and the area looks white, the reason why it's because you have this excess keratin that's formed, okay? Or sometimes you can also look white because this epithelium is actually much thicker than its usual thickness, okay? So usually if it's like 10 cells thick, then it gets, it increases in its thickness, okay? So there are two things that can potentially be responsible for the lesion to look white. One would be because you have increased in the thickness of the epithelial layer, or there's increased keratin that's being formed on top, okay? And those two can look white in a patient, clinically, yes?
I heard this can lead to oral mouth cancer. Is that true?
No, it's not.
No.
No.
Okay.
So the old thought process was, if you have, these kind of habitual, things that can lead to chronic ulcerations in the mouth, then that would lead to like precancer and cancer, but this does not. This is not a predisposing factor. If you do have a chronic non-healing ulcer on the side of a tongue, then you should be concerned because that's a high-risk site. And then we'll talk about that when we go to ulcerations. I'll show you some examples of different ulcers. But this is not actually an ulceration, right? So this, all you're seeing is changes on the superficial layers of the epithelium, right? So if it's an ulcer, what happens is you actually have a break in the epithelium and then it kind of burrows down into the connective tissue, okay? That presentation is very different from actually deposition on top of this, on the epithelium. So this, if you have to think of it, it's more like a callus underneath your foot, right? So if there's a lot of friction, and then, body has to respond, right, to that friction. So what it does is it creates this callus, underneath our feet as a protective response. And that callus is basically just keratin, okay? So that's very similar to what happens here. So body is responding to that physical injury by creating this keratin layer, and then that's why it looks white, and it's body's way of saying, okay, I'm going to respond to this constant insult in my mouth, by creating this, keratin layer. Make sense? Yeah.
So basically what we saw in the buccal mucosa was keratin.
Yes. So most of the times it ends up being keratin, but occasionally it could be just the epithelium, just thickening in its length, right? So you have much more thickness of the epithelium rather than its normal thickness. So it could be both sometimes, but majority of the times it tends to be keratin. Okay. Any questions? Okay, so, and then this cells that you're seeing all the way on the top, these are actually all bacteria, these blue cells that you're seeing there. Okay, so a lot of times, bacteria and debris, they're kind of mixed up with this shredded tissue, and then they can have this appearance. So how do we treat it? As I said, again, there's no specific treatment. You want to encourage patients to quit parafunctional habits. If it's associated with stress, you want to, basically refer them to an appropriate specialist so they can do stress management techniques. And then some clinicians have used this acrylic shields, but this is not something that we would recommend because occasionally what can happen is when you use these acrylic shields, it can actually rub against the tissue even more and actually exacerbate the problem rather than helping that, okay? So it's better not to use these, So you just want to be as conservative as possible. So your recommendations for your patient, if you see this, would be, this does not require treatment, this does not require a biopsy. Please quit any parafunctional habits if you're aware of them. Okay, and if you come across anything else in the history that you think they require a physician referral, you go ahead, place that referral for them. Okay, so linea, alba, and morsicatio, both, there's no treatment. Okay, you just have to ask patients to quit the parafunctional habits. And then the difference between linea, alba, and morsicatio is, one of you guys, why don't you tell me, what is the difference between linea, alba? What does it present as clinically?
One line.
As a white line, right? Where do you see it? On the buccal mucosa. At what? At the occlusal plane. Okay. And how does morsicatio present? Morsicatio baccarum? So it's more generalized. It's more diffuse presentation. It has a shredded appearance, and it's a white lesion, right? Okay. And then both of them, as I said, don't require treatment. Okay, so then we're going to look at traumatic wounds, right? So we're basically still continuing physical injuries. Okay, so physical injuries, you can have linea, alba, morsicatio, and then you can have different kind of wound patterns. Okay, and whenever you have a mechanical force to a soft tissue, a skin or a soft tissue, body has to respond, right? So it basically creates there's different types of injury that you can see when you have a mechanical force applied to a tissue. So the first type of pattern of injury, it's abrasion. So what does abrasion mean? So if you have a skin layer, right? So without any prior idea, when I say abrasion, what does that mean to you guys?
It's like something rough.
So it's something rough, okay? And then if I say my skin is abraded, what am I saying? That it's scraped, right? So that's basically what it is. So if you have a wound to a skin surface, okay, that either scrapes or rubs it, okay? So there's only damage. So when I say my skin is abraded, I'm saying basically that only the top layer is injured, right? Because it just scrapes the top layer. Okay, so abrasion basically means it's a kind of injury or a wound pattern where only the top layer of the skin is affected. Make sense? Okay. Then you have something called a bruise or a contusion, right? So when I say I'm bruised, what do I mean in lay terms? I'm sorry? You have a damaged blood vessel. When I see a bruise on my skin, I'm basically saying that I had some kind of trauma to the skin surface, and then it basically affected the blood vessel in that area. So the kind of trauma that you have, it's not a sharp trauma, it's a blunt trauma. So when there is a blunt trauma to a skin surface or a soft tissue, and then the result of that trauma is actually a damage to a blood vessel in that area with actually extravasation of the blood. Do you guys know what extravasation of blood means? So when you have a blood vessel, right? And then you have trauma to the blood vessel, and then it gets injured. So blood has to come out of the blood vessel because it doesn't have an intact surface anymore, right? So it ruptures. So blood actually comes out of the blood vessel and then pools up underneath the mucosa. That's how you see a bruise, right? So it's basically blood seeping out of a blood vessel because, the integrity of that blood vessel is damaged because there's some kind of blunt trauma to it. So that's your contusions or bruises, okay? So then you have another kind of injury, right? So you have laceration. When I say laceration, what does that mean?
Cut.
It's a deeper cut, right? So you actually have a tear. So an abrasion was just scraping of the surface, whereas a laceration goes a little bit more deeper, right? So you actually have a tear or a disruptive stretching of tissue. Again, this is secondary to blunt trauma. Okay, so blunt force injury can cause a contusion or a bruise, right? Or it can cause a laceration. And then abrasion is just a scraping of the surface, okay, of the top layer. Then you have an incision, incised wound, right? Again, when you say incised wound, that means something different, right? When I'm saying I'm making an incision in the tissue, I'm using something sharper, right? And it's a little bit more deeper. So you actually, what you do is, there's much more significant damage to the blood vessels in that area when you make an incision, right? And then you have a puncture wound. Okay, when I say puncture, what does that mean? So puncture means you take something a little bit more narrow and you're just like making a hole, right? It's like a pinpoint kind of injury, okay? So basically you're seeing it secondary to a long, narrow instrument as a puncture wound, right? And then you can have different types of puncture wounds. You can have something that's penetrating or something that's perforating. So penetrating means this instrument that you're using, which is this long, narrow instrument to make a puncture wound, it actually pierces the tissue completely, okay? But then when you have a perforating wound, it actually goes through the tissue, but it has an exit too. So it comes through and through, right? So you have an exit wound. So that's a perforating wound. So you make a puncture with this instrument, but then you create an exit wound for this to come out, right? So that's called perforating kind of wound. So what are the different types of wounds that you can see? So you can have abrasions, you can have contusions or bruise, you have laceration, incised wounds, and puncture wounds, right? So there's 5 different types, okay? So what does abrasion mean? Just scraping of the surface, right, of the top layer, okay? What does contusion mean, or a bruise? So you have a blunt trauma, and what happens because of the blunt trauma?
Blood vessels
So you have a damaged blood vessel because of a blunt trauma, and then so you have blood pooling in that area, okay? So that's your contusion or bruise. How about a laceration? Okay, so you again have a blunt force trauma, but this actually causes tearing of the tissue there, right? And yes.
That would cause bleeding. Was that
Yes.
the start of the bleeding?
Yeah.
Would be this one?
And then how about incised wounds?
Surgical sharp instrument.
Incised basically means something more sharper, right? A sharper trauma, it's not a blunt force trauma anymore, okay? And then that also can actually, sever the blood vessels in that area when you make an incision, right? How about puncture wounds? So using a long, narrow instrument, and then that puncture wound can be a penetrating wound or a perforating wound. Penetrating basically means it goes through the tissue. Perforating means it goes through the tissue, but it comes out too. So you have an exit wound, okay? So 5 different types: abrasions, lacerations, contusions or bruises, incised wounds, and then penetrating wounds, okay? And penetrating puncture wounds. Puncture wounds can be both penetrating and perforating, okay? So these are all considered physical injuries, right? So far, what are the 3 physical patterns of injury that we talked about? What the manifestations? Linea alba, Morsicatio Mucosae Oris, and then traumatic wounds, right? And then, so to move on from traumatic wounds, we're going to move to this topic called traumatic ulcer. So the wounds that we talked about right now, they were either just a superficial scraping, or you have a deeper wound that caused, blood vessels to, kind of get injured in the area. So there's different patterns that we looked at. But when you talk about an ulcer, what does the term ulcer mean?
The top layer is gone.
So, okay, so when you, do you guys know the different layers that basically cover the inside of our mouth, or the skin layers? So what is the top layer called? Epidermis or epithelial layer. Okay, what is the bottom layer below that? Dermis, okay, which is the connective tissue layer. What is your connective tissue composed of? The dermis. It has blood vessels. It can have fat tissue.
Collagen?
It can have fibrous tissue, which is the collagen. Yep. It can have muscle. It can have bone, depending on the location, right? Obviously, in the lip, you're not going to have bone, But if you're looking at tongue, you're going to have a lot more muscle, So it depends on the location, but you can have salivary glands if it's on the inside of the lip. So those are different normal components of your connective tissue. Yes?
Is this still a physical injury?
This is still a physical injury. When you say traumatic ulceration, anytime you're looking at trauma preceding something, the likely possibility that it's a physical injury. Okay, but if it's a chemical injury or if it's a thermal injury, you're going to call it chemical or thermal, preceding that. So traumatic ulcers, why do we see these? So when you look at these different layers, right, whenever we talk about an ulcer basically means you have a disruption in this top layer, the epithelial layer, and it goes down all the way to the connective tissue. So you actually have exposure of the underlying connective tissue because your top epithelial layer has peeled off. Make sense? So that's your ulcer. Okay. So why do we see an ulcer? It could be an acute injury or it can be a chronic injury. Think of some examples. What would be considered a good example in the mouth that can cause an ulcer? I'm sorry? Okay, so if you're biting really aggressively, yes, you can ulcerate it. Yeah? So an object that gets placed inside, that can cause the tissue to, ulcerate.
Something like acidic or like something like burning?
So
almost?
typically that just, affects the top layers of the mouth. It doesn't cause enough damage to cause an ulcer.
Like
But a chipped tooth, right? Actually, a chipped tooth or a fractured restoration. So if you have a tooth that's broken down, or if you have a filling that's broken down and you have a sharp surface in that area, that can constantly, if it rubs against the mucosa in the mouth, that can lead to an ulcer, right? Because it keeps, abrading that tissue in that area and then eventually cause the ulcer. Okay, so you have to have a source of trauma usually in order to call something traumatic ulcer. Okay. So what are the different sources of trauma? Would be your biting, as one of you guys said. It could be, biting of your cheek, lips, tongue. It could be from an appliance. So if you have somebody with an ill-fitting appliance, right, like a complete denture or a partial denture that keeps rubbing into the mucosa, adjacent to it, that can lead to an ulcer, right? It's a chronic injury. Again, sharp food, that we talked about, something that's like chips, or like popcorn and stuff, something that can have a sharper edge to it. If it constantly rubs against the tissue, then it can cause an ulcer. And we have all had that, right? Where you had like a popcorn kernel get stuck in the roof of our mouth, and then cause an ulcer there, It's pretty common to see that. So that can cause a traumatic ulcer. Another common thing that we can do as dental professionals is when you're doing a dental procedure, right? And you take a cotton roll and you put it in the patient's mouth because you want to get, isolation, right? You want to avoid moisture getting into that area. But then when you're removing the cotton roll, what are you supposed to do? Wet it, right? If you don't wet it and then you peel off a dry cotton roll, what do you think is going to happen to the tissue? You're going to tear it, okay? And you'll cause an ulcer. So that's iatrogenic, right? That it's induced by us. And I have done this, I don't know about you guys, but when I brush really aggressively, sometimes I jab myself with the back of the toothbrush and then I create an ulcer in my mouth, okay? So that's again very common, right? Sometimes when you're not being careful about the way you're brushing, you can injure yourself and cause an ulcer. So there's things that could be done by us, as patients, that we injure ourselves, okay? Or it could be iatrogenic. That means it's actually done by the professional, that can cause this kind of damage. So what do we see here? So now let's look at some of these. What do we see here? What part of the mouth is this?
Under the tongue?
It's the tongue. So these are your teeth right there, and this is the lateral aspect of the tongue. Okay? So what do we see on the lateral aspect of the tongue right there? Let's first and foremost, what we need to do is learn how to describe lesions, right? So if you saw this lesion, would you describe it as an exophytic lesion? Do you guys know the difference between an exophytic, endophytic, and... Okay, so exophytic lesion means if you have a skin surface like this, right? And, forgive me, I don't have props, but I'll try and use my hand. So if you have a lesion that kind of sits on top of the skin surface, okay, you call that exophytic, okay? Now, instead of so if you have like a cup-like depression in the skin surface, so it's not going outward, but going inward into the connective tissue, you call it endophytic. Okay, so that's your difference. So if you saw this, would you call it exophytic or endophytic or like an ulcerated lesion? An ulcer means you have a break in the membrane, in the continuity of the tissue. Yeah, so this is not really, it's hard because this is a superficial ulcer, right? So I would call it an ulcer, but it's not endophytic enough. So that means it's not deeply burrowing into the connective tissue, okay? So I would describe this as an ulcer. Again, when you look at an exophytic lesion, a good example for that would be, have you guys ever seen a wart on the skin? Okay, a wart in the mouth, right? That's an exophytic lesion because it's sitting on top of the skin layer or on the mucosal layer, right? And then if you're looking at, have you guys ever seen fibromas in the mouth? Little lumps in the mouth that kind of protrude out, okay? And when we get to that lecture, you'll see it. So it basically, those are called exophytic again, but they are more nodules, okay? Have you seen pustules in patients' mouth? When they have like an abscess tooth, and they get like a little abscess right next to the tooth and it's full of pus and it kind of starts, you know, if you press on it, pus comes out. So those are considered pustules. They're also exophytic lesions. So exophytic lesions can present in many different ways. It can be a firm lump, it can be like a pus-filled structure, or it can be like a vesicle or a bulla. Okay, yes?
So what about fistulas?
So fistulas, so it's an opening or a tract. Okay, so it's actually, if it's associated with a mass at the end of the fistula, then you call that an exophytic lesion. But a fistula is just a tract. A sinus or a fistula is basically are just like long, narrow pathways, so that connect the tooth that's, you know, infected to the outside mucosa for a way for that infection to kind of come out. Okay. Yes.
I just got a question because I was kind of confused. So an exophilic lesion is a type of ulcer?
No. So exophytic lesion is anything that is a lump or a bump that kind of protrudes out, you know, of the skin surface is called an exophytic lesion. An endophytic lesion, an ulcer is an example of an endophytic lesion, right? But an ulcer can be a superficial ulcer or a deep ulcer, okay? So that means it's actually, instead of going outward, the lesion, it's going inward into the connective tissue. Does that make sense? Like, I'll show you an example of an endophytic lesion. Look at this one. So this would be considered an endophytic lesion. If you see the inside of it, like look at the center of it, right? So this is an ulcer. This has a rolled border right around it. But if you look at the center of the lesion, it looks like it's actually making a hole into the connective tissue, right? It's burrowing into the connective tissue. So that's your deep ulcer. That's an endophytic lesion. But if you didn't have this ulcer in the center and it looked like this, you know, lump on the top, then that would be considered exophytic lesion. Make sense? Okay, so. No problem. Okay, so this is basically an ulcer, but it's a superficial ulcer, right? So whenever you see a lesion like this in your SOAP note, you have to learn how to describe them, right? So in your objective component, when you're doing an intraoral examination, you have to look at, okay, so you're going to describe this as an ulcer. Is this a single ulcer or is it multiple? Single. So you call it a solitary ulcer. And you have to write the location of the lesion, right? So which would be your left lateral tongue. Okay, and then is it just an ulcer or is there something else going on around this lesion? Okay, we don't use the word linea alba. We use the term linea alba only if it's a white line on the occlusal plane on the buccal mucosa. So what we wouldn't use the term Morsicatio either because they are diagnostic terms to describe specific process, right? Here you say you have a superficial ulcer with a white, you know, periphery around it. Okay, so you have radiating white lesion, you know, around the periphery of this central ulcer is how you would describe it. Okay, yes?
Like corticated, uncorticated?
When you use the term corticated, you're describing radiographic lesions. So we do not use the term corticated and uncorticated for soft tissue lesions. Okay, so if you, what you're seeing is here, it looks like there's a white patch, right? And it's basically surrounding this, you know, central ulceration. It's at the periphery of it. and it's kind of radiating out, right? It's kind of like a sun ray, it's kind of splitting out from the center. So that's basically what we're seeing there. Okay, so that's how you describe that. And then, so you're describing the location. You have to describe the size of the lesion in your descriptions. So you can take a perio probe and use that as your measurement when you're measuring the size of the lesions. And then you have to describe the shape. Okay, so if it's a circular lesion, if it's a linear lesion, and what would you consider this? This would be a circular lesion, right? So it's the location, we have the size, we have the shape. You have to describe the surface of it. Okay, when you look at the surface, does it look like it's an intact surface or if it's broken down? Okay, it's broken down, right? Because if you compare it with the adjacent mucosa, this is your normal mucosa, right? So this is normal pink. Okay, there's no break in the mucous membrane. Here, you have a break in the mucous membrane, right? You actually have an ulcer here. So you have to describe it as an ulcerated surface, right? Or there's a break in the mucous membrane. Okay, and then when you're describing it, you also have to use your fingers to palpate it. Okay, and then you have to say if it's tender on palpation. So does the patient feel pain when you palpate it? So these are all the things you have to include in your objective examination, because if you learn how to describe lesions appropriately, then that's half the struggle. If I see this and if I describe this as a superficial ulceration, that's a single ulcer, on the side of the tongue, basically I can eliminate anything that can present differently from my differential diagnosis, right? I'm only going to focus on things that present as ulcers and that present as single ulcers in my differentials. Okay, so different diagnosis. So anytime you see something like this, right? This is basically a traumatic ulcer. Okay. Anytime you have an ulcer in a patient's mouth that does not heal, the first and foremost reason why you see an ulcer in a patient's mouth is because of trauma. Okay, so traumatic ulcers should always be on the top of your differential diagnosis if you have a non-healing ulcer in a patient's mouth. So if you saw something like this, what is it that you need to look for? Is look in a patient's mouth to see if you can find any source of trauma. Does the patient have a broken down tooth, a broken restoration? Do they have a habit of, biting on their tongue, on that side, constantly? What is it that's potentially causing this trauma, right? If you're not able to find a source of trauma, then you have to think of other things that can potentially cause ulcers in the mouth. The other reasons could be squamous cell carcinoma, right? Because it's on a high-risk site. It's on the side of the tongue. That's considered a high-risk site for squamous cell carcinoma in the mouth. So you would consider squamous cell carcinoma in your differential. Sometimes you can also get deep fungal infections. And when we do infections, we'll learn more about that. There are certain kind of fungal infections that can present as non-healing ulcers in a patient's mouth. Okay? But you always have to consider trauma on the top of your differential. Yes?
Would an immune response be later touched on as far as ulcerations?
Yes. So basically, if you have a single ulcer, the likelihood of this being related to an underlying immune condition is a bit unlikely. So when you have an immune-mediated process that causes ulcers in the mouth, they tend to be multiple ulcers. Okay? So there's one exception to that. There's something called recurrent aphthous ulcers, which Dr. Richards will talk about to you guys next week. No, actually on Friday. She'll touch upon that. So those, they can present as single ulcers, okay? But then they can be seen anywhere in the mouth, not just in the high-risk sites, okay? So you can see them on the inside of the lips, inside of the cheeks, pretty much vestibule, anywhere, it has to be movable tissue. But when she gets to that point, it'll make more sense when she shows you examples of that, okay? So you have to try and figure out what is the source of your injury. So this is another example, and this is different presentation when you look at this traumatic ulcer, right? It's not as clean as the other ulcer, but it's still well defined. It's still localized. It's still in an area that can potentially get injured. So you have to look in a patient's mouth to see, do they have a sharp tooth, a sharp restoration, or anything in the history that potentially could cause this. If you're not able to find that, then you have to look for other reasons why, you see this. So I'm just going to show you a couple more examples and then we'll finish the lecture. So whenever you see a non-healing ulcer, an area that looks like it's broken down, it's not intact, you have to think, as I said, trauma would be something you would consider first. Then you have to think of squamous cell carcinoma in your differential. Then you can think of deep fungal infections, or sometimes bacterial infections like TB or syphilis can also cause non-healing ulcers in the mouth. Okay, so this one is an example of, so if you saw these two ulcers, can you tell me which one is a squamous cell carcinoma and which one is a TB ulcer? It's hard to tell, right? Just by looking at it. This is a squamous cell carcinoma and this was a TB ulcer. Okay? But again, both of them can present as these single ulcers. Okay? And they both have this endophytic component to them. So that means they're going into the connective tissue. This one is not as well defined, but you can have squamous cell carcinomas that can look exactly like this, like a TB ulcer. Okay, so it's hard to tell when you have presentation like this. So that's why a differential diagnosis is critical in cases like these. So if you have a patient that has an ulcer that does not heal, for a long period of time, okay, so they've had it more than 2 weeks and it's not healing, you have to look for source of trauma. If you're not able to find the source of trauma, then you have to recommend that the patient get a biopsy done, because you want to rule out a possibility of squamous cell carcinoma or other infections that can potentially do this. Okay, so let's stop right here, and then on Friday we'll continue, and then we'll revisit ulcers again. Okay, on Friday. Yes.
When do you start teaching?
I'm sorry?
When do you start teaching?
What do you mean?
When do you become often do we have?
This is oral path.
I know, but the rest of kind of, yeah.
So she's still going to be, so we're going to be splitting the oral path topics. So if you, there's some topics that I'm going to teach, and then some topics that Dr. Victor is going to teach.
The oral path, is it for you or for her?
Both. So I'm going to be teaching some topics of oral path, and then she's going to teach some certain topics.
Hey guys, can we just vote really quick?
So whatever is my portion of it, I write my questions. Cool, thank you. No worries.
Do you want to just put it on Facebook and we could...
Let's just do it now so we can just pass it out.
Who on Monday?
Because not everybody votes on Facebook. All right, who wants to put this on Monday? Okay. So Fridays? Okay.
I thought you were close. Oh, okay.
But I'm gonna go up there to check.